It seems like it's been 40 weeks since you got 40 winks. Your back pain? Unbearable. Tossing, turning, trying to find that pain-free position. And that's the moment you realize you can't spend another waking moment putting off treatment.
The Joint and Spine Center is Cincinnati's leading destination for spine care, with a ton of surgical and non-surgical treatments for back pain. So when a moment has the power to change the rest of your life, go to the one place with the power to change it for the better, the Christ Hospital Health Network. This changes everything.
The Pound This podcast is brought to you by the Christ Hospital Health Network. This is the Pound This podcast, episode 740. In case you missed it, Keto Diet for Weight Loss, the Good and Bad, with Dr. Joel Forman.
I want to lose weight, but I don't know how to get started.
What should I meal prep every week?
How do I get those sweet booty gains?
Inspiration for your healthy lifestyle. The Pound This podcast with Amanda Valentine.
Thank you so much for listening to the Pound This podcast. I am Amanda Valentine. Before we get into this episode with Dr. Joel Forman, by the way, this is an In Case You Missed It episode. This originally aired in December of 2018, so it's been a hot minute from this episode recording, but so many people ask me personally about the keto diet. I thought I would let a doctor answer that question, so that conversation is coming up in a minute. Someone else I want to tell you about, though, who would probably be very happy to have a discussion about diets in general, especially the keto diet, is Sarah from Team Fit With Me, who has been my personal health coach for the past year and who has been involved with this podcast since 2018. Sarah has an amazing health journey herself and started her own business and health coaching from her own weight loss journey, from her own health and fitness journey, and now she wants to help you do the same. So if you want to learn more about macros, nutrition, fitness, Sarah's got you covered. If you have anything like PCOS, thyroid diseases, gut health conditions, hormonal dysfunction, Sarah can help you through that. There's meal plan options. There's a food relationship coach partner. I mean, she's got a whole team of amazing women that want to help you out. So if you're interested, you can get 10% off month one of all packages, plans, and add-on services when you go to teamfitwithme.com/poundthis, and you will find that link in the show notes. Right now, let's talk about keto with Dr. Joel Forman. My special guest is Joel Forman, and you are a cardiologist at Christ Hospital, correct? Is that the correct term?
Correct.
And you work in preventative care.
I focus on preventative cardiology, trying to prevent people from having cardiovascular events, heart failure, heart disease, stents, heart attacks, that sort of thing.
Well, I think that's awesome because I think that most people think of a hospital and a cardiologist, you think, oh, I've had a heart attack, I've had a heart event, and now I need you. But, you know, you're there to help them so they don't have to have that event.
I try to keep them from my colleagues that do that for a living. That's my goal.
So what does your average day look like? Like, what kind of problems are you dealing with?
Well, I'm a general cardiologist first and foremost, so I see the things that cardiologists see: atrial fibrillation, heart failure, people with history of coronary disease and stents, and treat blood pressure and treat cholesterol. And one of my long-term interests, and my wife reminds me of this, has just been preventing people from having problems. And I've always been very focused in my practice on lifestyle. And I'd like to think I talk to every patient about diet, exercise, and I try to talk about sleep and stress management. And I really enjoy it. I think it's an interesting patient population that's very motivated, and it's fun to prevent problems as opposed to palliating them and treating them when they occur. So I've spent some extra time, focusing on that and educating myself about that, and specializing to some degree in preventive cardiology.
So is that what your intentions when you went to medical school were? Is it kind of that just led you in this direction?
My path kind of led me where it led, and I've always been very interested in exercise and nutrition, and I've worked out basically my whole life. My mother will remind me that my nutrition wasn't very good. I remember telling me in high school, you work out and you play basketball all the time, and then you go to Burger King. But
I mean, that's what teenagers do.
It's true. I fell into in internal medicine and then subsequently cardiology when I was a resident at Emory. My first rotation was on the cardiology service during the '96 Olympics. I recall it very well. And it kind of caught my fancy. I enjoyed it. I enjoyed being able to make people better. I enjoyed the wide variety of things that we took care of. and helping people. It just kind of struck a chord with me, and I'm glad I do what I do.
So like a patient that you would see would be like, I have heart disease, it runs in my family. I want to make sure that this doesn't happen to me. And then they come to you and you give them advice?
Right. So what the basis of preventive care is really primary care physicians, family practitioners, internists. And the basis of prevention is really the American Heart Association has something called Life Simple 7. And Life Simple 7, less than 5% of the population achieves that. And if, in fact, they do, they have very low chances until very advanced age of having heart problems. And that's maintaining a healthy body weight, not smoking, eating a good diet, exercising, controlling blood sugar, controlling blood pressure, and controlling cholesterol. And that's really the focus of prevention. But then there's some people that have particular problems, familial lipid problems, unusual risk factors. Many physicians, myself included, order something called coronate calcium scores, which look at the amount of atherosclerosis people have as implied by the amount of calcified plaque. So they'll come in and say, I'm 50 years old, I don't have a family history, why is my calcium score 400? And we'll drill down a little bit more. It's a little more intensive risk factor modification, looking at advanced lipid profiles, talking to people about diet, talking to people about exercise, controlling blood pressure per guidelines, and that's really the basis of preventing heart disease. It was probably about 10 years ago in the New England Journal of Medicine, they modeled the improvement in cardiovascular mortality over, I think the time horizon they said was about 10 years. And about 80% of it is medical therapy and risk factor control, the stuff you read about in the paper, and those are very important things. Don't underestimate those. They're fabulous for the people who need them. But in terms of preventing mortality and preventing events, it's really these fundamentals that prevent people from having problems. And I try to focus my practice on that. And, we tend to order a lot of medicines. We tend to order a lot of tests in medicine. And I think it's also really important to focus on how people live.
Yeah, it feels like everything kind of, other than like genetics and having problems, everything kind of really boils down to lifestyle. Right. Of how you're moving your body and how you're eating, which I think just perfectly leads into, our discussion we're going to have about the ketogenic diet. Right. Is because I think it's important to talk about because it's, I've seen so many people discuss this on Instagram and Facebook and everything like that. And for me, I kind of have a very vague idea of what keto is. Like my idea of what the ketogenic diet is just like super low carb. But I know the goal is ketosis, but I don't even know what that means.
So what happens is the keto diet tends to be fairly high fat, moderate protein, very low carbohydrate. And what happens is when your body gets very minimal carbohydrates to not meet its metabolic needs, there's a backup fuel system, if you will. And when you take in carbohydrates, you release insulin. Everybody's heard of insulin. Mm-hmm. Insulin prevents resorption of fat and promotes storage of sugar. Well, if you don't have sugar to stimulate the release of insulin, what happens is you break down fat. And as part of the breakdown of fat, you form ketones. And there's 3 different ketones, and I'm far enough from medical school that I forget exactly the names of them. But you basically are putting your body into a very, very low carbohydrate state where you stop producing insulin. And the theory there is to burn fat, to burn your endogenous fat. You use these ketones for fuel for your brain, I think for muscles as well. And, what I would qualify first to start with is, I'm a cardiologist. And when we talk about the keto diet, my focus is going to be on cardiovascular health and health outcomes. First of all, the keto diet is a 100-year-old diet. It was invented in the 1920s. And I think the most standardized medical use for it is in refractory epilepsy. I have no expertise whatsoever. Yeah. And if anybody listening, their doctor has put them on that for epilepsy, this is certainly not to discourage that in any sense. I also think there's a difference between necessarily weight loss and health. Not all weight loss is necessarily healthy. You can get very sick and lose weight. It doesn't mean you're necessarily more healthy.
Oh, it's just like you could take diet pills and lose weight, and that doesn't necessarily
or you
mean
can get gravely ill and lose weight.
Yeah.
And, God forbid you have, a terrible malignancy or a terrible infection. You'll lose weight.
Yeah, so that's what I just wanted to mention keto as far as like a weight loss tool as a diet, not for medical needs, because that's the people that I'm seeing, doing it. And I've seen people have like really great weight loss success, like people that have lost like over 100 pounds on keto. But like, does that mean it's long term? I know that if you can eat that way the rest of your life, then does that, I guess the weight loss will stay the same? I don't know. Or does it?
I don't think we know long-term studies on health outcomes with the keto diet, at least as far as I'm aware. And by long-term studies, I mean, does this prevent people from having heart attacks? Does this prevent people from having strokes? Does this prevent, the long-term development of diabetes? You certainly do lose weight on an appropriate keto diet, and probably you lose weight at a higher rate than a low-fat diet. Remember the Snackwell's era of the 90s, and everybody ate sugar. Diet's hard to study, though. Diet is difficult to control, and you can't keep people on patterns forever. People have reasons, many of them financial, many of them cultural, many of them availability of food, why they're on a particular diet. So it's difficult to do a randomized control of diet and look at health outcomes. But you will lose weight on a typical keto diet. Now, some of that is fluid depletion. Some of that because ketones in the blood lead to what we call an osmotic diuresis. In other words, those ketones are filtered by the kidney, and then you urinate out extra water. So if you go on these diets, it's very important that you maintain very vigorous hydration with that.
Gotcha. So you said that the keto diet is over 100 years old. So how is the keto diet different today than it was then?
I don't have a real historical perspective on it. I think it's become much more popular recently in terms of using it for weight loss. It was used way back when medically for epilepsy. And the little bit I know about it, there are certain people that have done very well on it for epilepsy. I certainly don't dispute that, and I don't know anything about it.
Yeah. But I just see like a lot of people even describe themselves as doing dirty keto, which doesn't really seem like you could really do that in like 1904. You know what I mean? Of like, it feels like in 2018, you can have your bacons and ranches and I'm not even sure what is all keto approved, but that there's more of those highly processed, high-fat items than there would have been 100 years ago.
Sure. The data that I know really says that plant-based fat, plant-based protein is only better for you than animal-based fat, animal-based protein, and whole foods and real foods are better than processed foods. And with any diet, the quality of the foods you're eating and how natural your foods are, I think, naturally leads to your health outcomes. This dirty keto, on any diet, people can learn the rules and work around the rules. Sometimes it's still achieving the goals of weight loss.
Yeah.
But whether that's good, solid nutrition, I would argue there's a big difference in a keto diet, eating a bunch of vegetable products and vegetable fat and, lean chicken breast and grass-fed beef than, going to a fast food restaurant, taking a bacon cheeseburger, taking the bread off and eating that. I mean, I don't know many people would argue that the latter is good nutrition. I think you could make the argument that there's nutritional benefits of the former for sure. And I believe what I described is very low carbohydrate, and you could generate ketosis with that.
So if somebody is choosing to do the dirtier route of keto and they are losing weight and it's going awesome and they're feeling encouraged to keep doing that, like being a cardiologist, like what does something like that do to your heart?
I wouldn't encourage that. In terms of, nutrition, we want to eat whole foods. We want to eat real things. Cardiovascular outcomes, really every diet that's been associated long-term with positive cardiovascular outcomes has involved plants.
Mm-hmm.
I'm an advocate, not necessarily of a vegetarian diet or a vegan diet. Certainly, I think that's a very healthy diet if people want to do it, but of a plant-based diet, Mediterranean diet, DASH diet is kind of the American Heart Association's version of that. But there's, in terms of nutritional quality, I think you have to pay attention to what you eat as well when you're following those rules. I think that's very important.
So, I mean, not even including keto, just any sort of like quote unquote like fad diet or just a diet that has a name, I guess. Have you seen in your job, seen anybody have like any bad effects from doing a diet like that?
Well, those things don't typically end up being sustainable, nor do they necessarily teach people how to eat and the way to live. Many people will yo-yo diet and gain weight and lose weight, and I'll sometimes joke you could go on the blue food diet for a month, eat only things that are blue. If you're restricting your calories and your nutritional choices, you'll probably lose weight. Again, my focus is going to be more health. What I encourage my patients to do is I tell them, don't worry as much about your weight. If you want to monitor this, sure, it's a barometer, and I'm going to look at it when you come in to see me every 6 months, but that's going to make you unhappy. And if you focus on your weight, that raises your cortisol, that raises your stress hormones, that makes you hungry, that makes you binge eat, that makes you not sleep. And all those things are being associated with weight gain, and weight is not necessarily my primary goal. My primary goal as a physician is health. If you focus on health and you focus on immediately actionable things, you can control what you put in your mouth, you can control how you sleep, you can control how you manage your stress, and you can control that you exercise. And then people tend, and I've had some patients that do this, they'll lose, a couple pounds a visit, and they're happy.
Yeah.
And they're not feeling bad about themselves if, they have a bad meal, which I always joke to them, you thinking that, you had a birthday cake at your grandson's birthday makes you, have a bad diet is as silly as thinking if you had a salad once a week that you're a healthy person. It doesn't.
Yeah, I think the thing that is people don't really want to hear that kind of advice because we're all impatient and we're living in this very fast-paced world, and you want the results right now. And I mean, I'm saying that I'm also guilty of that, and I have been. That's why I yo-yo dieted so long, of knowing that, hey, I'm going to have to eat healthier foods and move a little bit more, and it's going to be a slow process, and it's going to be ups and downs. Whenever you could be like, hey, I could just, take out all carbs or whatever your thing is and drop weight like now and have like really fast results. It's obviously very alluring of like, ooh, I can just drop the weight and I look great and here I have my before and after picture. But then, think 3 years down the line, where are you going to be then? I mean, I'm just speaking from my own experience of doing those sorts of things. And I tend to do way better with lower carb, and I tend to keep more low carb stuff. But I also know when I do carbs, I do quinoas and sweet potatoes, and it's the other stuff that I tend to binge eat and can't control. But it's if I go no carb, I know that I'll drop weight. But then once I start eating carbs again, because that's what I do, the scale's just going to go back up anyway. Not like in some insane way, but it's just balances itself out.
Sure. And like anything, I mean, there's certainly some truth that refined carbohydrates and sugar is a problem in the American diet. I mean, really, obesity took off in the 1990s when we went low fat and replaced it with sugar. And with diet, it's complicated too, because anything you eat or don't eat has a replacement effect. If you're eating fish, you're not eating a burger. If you're eating a big salad, you're not necessarily, eating something processed and sugary. And, sugar in and of itself is a little bit of an addictive substance. And sugar releases that very insulin that promotes the opposite of ketosis, which is fat storage. So I do think there's some truth behind the keto diet in terms of limiting carbohydrates, and there are some surrogate outcomes on cholesterol, which we know about, but we don't know the long-term health effects of it. And I think the other problem is we don't know how sustainable it is for people.
Yeah.
And there are some side effects to it.
So speaking of cholesterol, because I just feel like I have to ask this, like, are eggs okay?
We're learning from observational studies that fat isn't as bad as we thought it was. There's replacement effects to everything, and what they've looked at there was an article in, I think it was Time magazine, it must have been 8 or 10 years ago, that basically, I think there was like a pat of butter or some eggs on the cover, and it led to this kind of perspective that eat whatever fat you want. But they looked at it again, and I think it was an American Heart Association paper, and it depends what you replace fat with. So if you replace fat with vegetables, if you replace eggs or fat with vegetables and plants, fat is worse for you. If you replace fat with sugar and carbohydrates and, the snack wells we talked about, that's an adverse health effect. So in terms of eggs, it's first of all, egg whites are a very complete source of protein. They have little fat. There's a little bit of data on choline in egg yolks and production of something called, I believe it's TMAO, which is a proatherosclerotic compound produced by bacteria in the gut. And when you look at meta-analyses of fat, which are big analyses of diets in terms of what type of fat, in terms of mortality, when you look at trans fat and saturated fat. So trans fat is the stuff that the government has actually taken out of a lot of our food. There's small amounts in animal fat, and then saturated fat, which is animal fat. Trans fat and saturated fat are associated with increases in mortality, albeit not huge. Unsaturated fat, which is vegetable fat, fish fat, nut fat, is associated with lower mortality. In terms of my personal habits, when I like eggs, I like them a lot. When I make some eggs, I'll take three whites and 1 yolk, and I get some minerals, I get some fat there, but I'm not necessarily bombarding myself with saturated fat. Saturated fat still does, to some degree, although less than we thought it was, raise your bad cholesterol, which is associated in a linear fashion with cardiovascular events.
Okay, well, so since we're talking about fats, and you hear like avocado and nuts are healthy fats now, so does that mean I can just like go ham on those and eat like a ton of guacamole and still be cool?
I think everything in moderation, but I certainly don't discourage people from eating, vegetable fat, fish fat, nut fat. Nuts is a little bit of a qualifier because our serving size tends to be a lot more than what we're meant to have.
Yeah, see, that's the problem, because I love nut and I love avocado, but it's like, you just rack up your calories so quick with them. So, I mean, you could still gain weight from just eating healthy fats then, right?
Sure, you could. I mean, but the thing about nuts is there's a phenomenon in nutrition called nutrient density. So nuts, yes, you're getting a fair amount of calories, but you're getting fiber, you're getting protein, you're getting tons of vitamins, tons of minerals. It slows down digestion. It promotes satiety. And it's actually, nut consumption is associated with positive health outcomes and is associated with leanness. But, the serving size is not strapping the Costco Planters bin to your face during a football game.
That's unfortunate.
It's a handful.
Yeah.
And like anything, you need to pay attention to the amount you're eating. But I think the first thing in a healthy diet is quality of food. There's a recent study called the Pure Study where they looked at diet all over the world, and it's a little biased towards less wealthy countries has been one of the criticism of it. But basically the idea was they had this Pure Diet score, and it's been a while since I read it. And if you eat whole food and you eat real food, you're healthier.
Yeah.
And it even included, dairy. It even included unprocessed red meat was a thing on this score. I forget there were some other things on there as well, and I forget the score, but the study is called Pure, and it actually didn't show that saturated fat was so bad.
Awesome. Yeah, I think for me, everybody wants, tell me what to do. Like, make it easy for me, write out, like with keto or Weight Watchers or anything that's a diet, of like, write out my rules and I want to follow the rules. And it just makes life easier because I got enough other stuff to worry about. And I think that if you want to have a rule, for me, what's worked for me, a rule is that you know what's in your food. If like you know the ingredients, if you can't pronounce it, you don't know what that is. The ingredients list could fit in your entire palm of like what is all this stuff, then maybe you shouldn't put it in your body. And doing that, like I think is just. I think that's easier. I mean, it's not as sexy because those other foods taste really good, but it's to be like, okay, this is broccoli. I know it's broccoli. This is rice. It's rice,
and it's portable, and you can take it. Listen, if you go on a diet that's sustainable and really teaches you to eat real things, and you can maintain that, and some people need those rules. That's okay. But, pretty much everything you need to survive is in the meat department and the produce aisle.
Yeah, it's just not as sexy.
They have paper towels and laundry detergent in the middle. You need that too, but you're not going to eat it.
Yeah. Well, I know that you're more into cardiology than like the food, but like all of like the food science of how it's like engineered to like turn your brain on and all that fun stuff.
Right.
I don't know if that's I'm interested in that stuff. I don't know if that's your jam or not.
You're probably much more well-versed in it than I am. But, there's entities that they're designed to sell us food.
Yeah.
Which is different than nourishing us necessarily.
Yeah.
And I'm sure there is some science behind it. They're companies. They want to have you buy their product.
Mm-hmm.
And, the better it tastes, the more you're going to buy their product.
Yeah.
So the yummy factor is a big thing.
Yeah. So I love that you're so much into prevention of just, eat healthy, have a good lifestyle so you don't have to go in with a heart event. And so, this is an official program at Christ Hospital, right? What you do?
It's pretty, basic, but we're trying to look for patients referred from primary care physicians with an eye towards people interested in preventing cardiovascular events, people with unusual risk factors, people, do I really need that cholesterol medicine? People knowing what other tests do I need to do? Am I doing all I can? Sometimes people come in and say, listen, you're doing great. You're doing all you can.
Mm-hmm.
And, sometimes these worried well, you're doing them a favor by saying, really, you've done all you can. And, nothing's 100%, but your risk is very low. And the risk that you have, you're modifying. So we are trying to start a fairly formal program to see patients and have patient referrals with this in mind. There's some lipid basis to it, and treating cholesterol. There's brand new cholesterol guidelines that just came out over the weekend at the American Heart Association. So we're all scrambling to incorporate those. Although it's pretty much based on the data of the trial since the last guideline. So and we enjoy it. It's nice, and we can integrate, and if we find things, we can get people to the right places within the health system to get them taken care of. If in fact, oh boy, not only do you have risk, but you have a coronary stenosis, sir, and you're having anginal chest pain, we need to get this taken care of.
Yeah. So what makes this program different than the other programs?
It's really focus, and it's more than just hanging my shingle. I really have tried to spend a lot of time educating myself and specializing and interest in doing CME with this in mind, and it's becoming a little more of a subspecialty in cardiology. It's not quite a boarded specialty, and I don't think there's people in fellowship necessarily. I stand corrected because now I know that there are, but people focusing on preventing cardiovascular events, and it's fun and it's gratifying, and it's sometimes a little time consuming, but it's you have interested people that you can really know that you're helping.
Yeah.
And some of this is what's important to the patient. Is it more important to the patient to lower their relative risk from 5% to 4%, or to avoid a medication? And sometimes the answer is it's to avoid that medication, and that's okay. Patient-centered medicine and shared decision-making is really an evolving and improving thing in medicine, and I'm all for that. We just recommend things.
Awesome. So people that would benefit from this are people that maybe want to lower those medications or wouldn't have the family history. What kind of scope of people would come find you?
People with family histories of early disease, and by family history, we talk about men younger than 55, women younger than 65. I always ask the follow-up question, what did you think of these people's health? If they, assuming they knew them well, was it a surprise to you this person had heart disease? And if it wasn't, it bothers me a little bit less. We'll be referred people to get these calcium scores that look at the amount of atherosclerosis they have. People with strange lipid abnormalities, sometimes we'll get these expanded lipid profiles. How do I treat this? How do I attack this? People don't necessarily want to, people want to know whether they should treat their blood pressure more aggressively. Am I doing all I can? Many patients are fairly test focused. Do I need a stress test? I had one last year. Well, no, you're asymptomatic and your risk factors are controlled, and you had a stress test last year. You don't necessarily need to do that. So there's some reassurance to that. And then, there's atypical risk factors that we see, things like lupus, pregnancy-related complications like preeclampsia. If you've had those earlier in life, gestational diabetes, you're at higher risk of events, and we lose that in some of the bigger risk factors that we pay attention to.
So for myself, I saw my primary care physician at Christ earlier this year, and I learned that I'm hypotensive.
Okay.
So, which I just know very basics, which why I'm asking you this. I know it's like super low blood pressure. So what are like the risks with that?
Well, you're probably hypotensive because of the wonderful and incredible amount of weight that you've lost. And, one of the other things you want to make sure is that you're fluid replete. They're mean to us when we're medical students. I tell people when they talk about how low is too low a blood pressure, and I imagine everybody that went to medical school was asked the same question. How low a blood pressure is too low of a blood pressure? And the minute you answer with a number, you get scolded because it really matters in terms of symptoms. And we've become a little bit numb to blood pressure in our society. When you look at a systolic pressure of 115 compared to a systolic pressure of 135, that 135 has twice the cardiovascular risk of 115, but people get numbers of 115 at home and think they're low. What was your pressure, if I can ask?
Oh, I don't remember what it was. I know that after he told me that, I Googled it.
Yeah.
And the numbers that were officially what they said is hypotensive, I was a little bit below that.
Were you lightheaded?
I do get lightheaded. And it's funny because he brought that up. He's like, do you get lightheaded sometimes? I'm like, well, yeah, almost every day when I get out of bed, everything goes black for a second.
Okay.
And I will it's the whole set up too fast thing. Everything will go to black just for a second and kind of fade out. When I've donated blood before, I've gotten really lightheaded.
Right.
But I mean, it's not all the time, but it's funny because he brought that up and I just thought that's that's just how life is. And he's like, no, it's because you have really low blood pressure.
You're not supposed to be lightheaded when you're young. One trick that I'll sometimes tell people, and this can only help, is put a glass of mostly ice water on your nightstand when you go to bed at night. When you wake up in the morning, and we're all jump out of bed and have busy lives, and we pop out of bed and start our day. When you wake up in the morning, sit on the edge of the bed and drink that cold glass of water. And what that does is that gets you used to the sitting position. You get a little bit of volume in, and then the cold tends to raise your blood pressure, and I bet that'll make the black go away. I don't want you ending up on the floor like that.
Well, I was told because I also like to eat a lot of salt that was okay because I'm hypotensive. Is that true?
We sometimes encourage people who have that tendency to take in a little bit more salt. Although the American she likes that. The American diet isn't really lacking in salt.
Yeah, well, the thing is, because I don't really eat a lot of processed foods, and so everything that I have that has salt on it, I add the salt myself. Which I don't know if this makes a difference or not, but I like it. Is the pink Himalayan sea salt? No,
sea salt. The thing about it's still sodium chloride, but sea salt tends to come in bigger crystals. So for any amount of sodium, you tend to taste it a little more, and it's got a texture to it. If you're eating a very, very natural diet, our kidneys evolved to eliminate potassium and absorb sodium. Well, in the modern diet with processed foods, we feed it sodium and deplete potassium. And as a matter of fact, there's literature on blood pressure that says that the higher the potassium relative to sodium, not with a supplement, but in your diet is, the lower your blood pressure tends to be. So if you're eating a completely natural diet and you're adding a little sodium to it, my experience has been with profound weight loss is that people's blood pressures tend to fall. I think there's probably a phenomenon in your nervous system with that. People tend to also get a little bit bradycardic. That's experience.
Oh, what's that mean?
Their heart rate gets a little bit slow. Some of that may be conditioning related too. And the reason that may happen makes a little bit more sense is that as you lose weight, your volume of your heart tends to be used to feeding a larger mass.
Yeah.
And you lose the weight, so you still have a higher volume cardiac chamber, and to put out the same number of X liters per minute, you just don't need as many heartbeats.
Interesting.
But in terms of why you're, hypotensive, the numbers aren't as important as the symptoms. And the first thing is just to make sure that volume, so fluids.
Yeah, I have. Well, have you seen my giant water bottle here?
Yes,
that's a half a gallon. I do 2 a day, so I do a gallon a day. But I also drink an insane amount of coffee.
Right.
But that's so interesting. I never even would have associated that with the weight loss. But that makes total sense. Even like years later, would your heart still behave the same way?
I think the adaptation with the bradycardia would probably happen. It takes, when we detrain athletes, it takes a couple months for their heart to come back down to normal size. In terms of the blood pressure, I'm not sure why that's happening. Sometimes there's endocrine causes for it, checking adrenal levels and checking your electrolytes and things like that. Sounds like you hydrate yourself pretty well.
Yeah, I'm always in the bathroom.
Yeah, well, between the coffee and the water,
right?
I'm pretty similar actually, coffee and water. But I don't know why you'd be hypotensive. But keep up with your fluids. Try the cold glass of water in the morning. We don't want you blacking out and hitting your head on the bathroom floor.
Yeah.
That'd be bad.
It's never been that bad. That's only whenever I drink too much booze. So
that'll fluid deplete you as well.
Yeah, exactly.
Right.
Well, it was so awesome having you in. And if somebody wanted to make an appointment or do some preventative measures, how would they get in touch?
They can go on the Christ Hospital website and look me up, find my office information. I can give my phone number out if they want. I don't know if that's helpful.
Yeah, go for it. Throw it out.
It's 513-206-1320. Glad to see anybody with concerns regarding their cardiovascular risk and hopefully improve that. And thank you for having me on.
Yeah, thanks for coming in.
Enjoyed it.
AmandaValentineBites.com